Assalamu alaikum everyone. Today we're going to be doing celiac disease, which is a really important topic, and I cannot stress enough on how important it is. In our syllabus, it's under the malabsorption syndromes right here, and in rank order, it is right in the first order, and it is in capital letters. And when I went through the past papers, I did not find a page on which I did not find a question related to celiac disease. It is an inflammatory disorder of the small bowel. It occurs in genetically susceptible individuals in which they have an intolerance to wheat, gluten, oats. Basically, they have an intolerance to gluten, which is in wheat and oats and barley. It is a malabsorption syndrome, and the best treatment is a gluten-free diet, and we'll discuss this in the management. This is from our textbook, and it depicts the pathophysiology, and I just want you to remember that it is associated with HLA-DQ2. The clinical features may present at any age. In infancy, it may present when the child is being weaned onto cereals as diarrhea and malabsorption in the child. In older children, there may be some non-specific features such as delayed growth, persistent diarrhea, malnutrition, mild abdominal distension, pubertal delay, and short stature. In adults, it may occur in the third and fourth decade. It is found 2 times more in females than in males. It may present as malabsorption, tiredness, weight loss, folate deficiency, iron deficiency, anemia, oral ulceration, dyspepsia, bloating, undernutrition, osteoporosis. So these are all the presentations that can occur, and it may be associated with other HLA-linked autoimmune disorders. And the 2 or 3 that I really want you guys to remember are type 1 diabetes mellitus and thyroid disease, and also dermatitis herpetiformis. And so these are some of the disorders that it can be associated with. The investigations that we must do, first of all, we need to have a biopsy for diagnosis. So endoscopic small bowel biopsy is the gold standard in this case. And we need to take many biopsies, technically more than 4 biopsies from the second part of the duodenum and 1 from the duodenal bulb. So that's at least 5. On histology, you will find villus atrophy, crypt hyperplasia, and lymphocytic duodenosis. There may be some other causes of villus atrophy. The one that I want you to remember are celiac disease, tropical sprue, and dermatitis herpetiformis. Okay, so that was the biopsy. Then we need to do some antibody tests. Tissue transglutaminase is a serological test of choice. It's highly specific and sensitive. In fact, it is the most specific and sensitive test among the antibody tests that we're going to be looking at. However, it cannot be considered a substitute for biopsy, and the advantage is more accurate in patients with IgA deficiency, and we'll be looking at why this is significant. If this test is positive in adults, you still continue the gluten diet until a biopsy is done and a definitive diagnosis is reached, and then you tell the patient to go on a gluten-free diet. However, if it is positive in children, we can consider it a diagnostic, and in that case, we don't need to put them through endoscopy and biopsy, and we can proceed to put them on a gluten-free diet. If the test is negative, it means that the diet is adequately gluten-free and the treatment is going well. So this is obviously after it's become positive and the patient has been diagnosed. After that, if we get this test as negative, we can assure the patient that his treatment is going well and he's sticking very well to the gluten-free diet. Then we're going to go for anti-endomysial antibodies for IgA. These are sensitive and specific for diagnosis, except in very young patients, and it's not suitable for patients with IgA deficiency, of course, because we're checking for IgA and it's going to give us a false result. We can also check for anti-endomysial IgG antibodies. In hematology and biochemistry, we're going to perform a full blood count on which we can find microcytic or macrocytic anemia due to either iron deficiency or folate deficiency. On a blood smear, we may see features of hyposplenism, such as target cells, spherocytes, or Howell-Jolly bodies. Because of the undernutrition, we may have reduced concentrations of essential minerals and contents of the blood, such as calcium, magnesium, the total protein may be reduced, albumin, vitamin D. Then we perform serum IgA to rule out IgA deficiency. The other investigations that we can do are the measurement of bone density, and we do this in older patients or postmenopausal women as they have a higher chance of osteoporosis. Now, the management, which is extremely important, and it solely, I would say, lies on a gluten-free diet for life. So you cannot be taking in any gluten for life, and you need to be very careful. You need to read your food labels and make sure that there's no hidden gluten that you're taking in. You need to exclude your wheat, your barley, and oats. However, you can eat rice, which is a really important point, because these kind of rule out all the staples of our meals except for rice, which we can eat, which is great for these patients. If the patient is severely malnourished or anemic or extremely weak, we might consider admitting them to the hospital to restore their health. We can improve their nutrient and mineral deficiencies with supplements such as iron, folate, calcium, magnesium, vitamin D, depending on the specific deficiency that they have. We need to give them dietary counseling and a diet chart, preferably with recipes of all the gluten-free things that they can make and eat, and we must follow up. Follow-up is an essential part of the treatment. When they come up for their follow-up visit, we're going to test their tissue transglutaminase, and if it becomes negative, we can rest assured that the treatment is going well. If their condition is still not improving, we may want to consider repeating the biopsy, and if it may be another disease apart from celiac disease. However, if it is definitely celiac disease, then our last resort would be to treat our patient with immunosuppressive therapy, glucocorticoids, and even though this is a last resort, an absolute last resort would be surgical resection and parenteral nutrition, but this is obviously a very rare kind of this would be used in very rare cases and very less. As you can imagine, this is not exactly the most comfortable kind of situation. We're going to do tests for complications, and we're going to make sure that the patients either don't develop those complications, or if they have developed the complications, we're going to treat them accordingly. So the main points to remember: gluten-free diet, improve the nutrient and mineral deficiencies, go for dietary counseling, and repeat their biopsy if the condition is not improving. But usually it is the case that the patient is unable to adhere to the gluten-free diet. They may be taking in hidden gluten within other products that they may not realize have gluten, so counseling becomes very important in that case. Some of the important complications are osteoporosis and osteomalacia, especially in older patients and in postmenopausal women. These patients have a 2 times increased risk of malignancy, such as enteropathy-associated T-cell lymphomas, small bowel carcinoma, and squamous cell carcinoma of the esophagus. They may develop ulcerative ileitis, which presents with fever, pain. It may present with obstruction or perforation. In this case, we can perform barium studies or enteroscopy, or we may need to perform a laparotomy or a full thickness biopsy. Complications are less common in patients who strictly adhere to gluten-free diet, which is key in this case. These are some past paper questions, which I would highly recommend you guys look at. And I'm just going to stop this at each question, and you may pause the video and just look at them.